Hi everyone, I'm Dr. Faisel Syed.
And I'm Dr. Dan McCarter.
And you're listening to Faisel and Friends, where we believe access to primary care is a right, not a privilege.
Faisel and Friends is brought to you by Primary Care for America, a diverse collaboration of innovators leading the way towards comprehensive, continuous, and coordinated primary care.
Today, we're talking to Karen Johnson from the American Academy of Family Physicians and Dr. Padmaja Patel from the American College of Lifestyle Medicine about fixing the foundation, rebuilding with lifestyle medicine. Let's get started. Whoa, look at that. We haven't had a full screen like this in quite some time, Dr. Dan. It's been a while.
That's right. It is. It's good to have everybody here.
I know. We've got Karen Johnson and Dr. Padmaja Patel. This is wonderful.
Excited to be here.
Both Karen, Padmaja, thank you so much for joining us. Both Dr. Dan and I have been so fortunate to get to know you all over the last couple of years and just through meetings and, conferences and whatnot. And I was so excited. I remember it was last year I went to the American College of Lifestyle Medicine's annual meeting, and I went just for one reason. I wanted to meet Dr. Patel in person.
Truly, very kind of you to make that short, busy trip. I know you were very busy. You came from some other conference at that point. So thank you. Thank you for attending, even if it's for one day.
When I found out that the two of you were working together with coming out with this article about lifestyle medicine and value-based care, I'm just so glad that the calendars finally aligned, more on my part because of all my career stuff, trying to make it all align so we could finally have this conversation. It's a very important conversation about the relationship between value-based care, the different types of value-based care, and why it makes so much sense. Because really to do value-based care well, for those of us who've been in this space, you got to address the root causes. And so I guess the opening question, usually Dr. Dan and I like to start off a conversation with a question to kind of just open it up. And then it just becomes, a conversation from there. And rather than doing like the typical, hey, what's value-based care and how does it differ from traditional fee-for-service? I think most of the people who are listening, we've already gotten to that point. But actually, what I'd like to start this off and, with both of you is how does lifestyle medicine fit into the core concept of value-based care?
Padmaja and I just recorded a webinar this morning. We could on that very topic.
Cue the webinar.
Yeah, and Padmaja, I'll kick it off if you want to, and we can kind of, because I sort of paint the big picture of like sort of what's happening in value-based payment and care more broadly, and sort of a little bit of what's working and what's not. And Dr. Patel, I don't know that I've encountered anyone who does a better job than Dr. Patel of making sort of the reality of lifestyle medicine and the impact on both patients and clinicians come to life. So I think she tells that story pretty well, which has been part of my inspiration to lean into sort of this conversation and this work at the AAFP. So, the premise of sort of all of this is that we use lots of words to describe what is at its heart very much the same thing. And that whether that's saying high quality primary care or advanced primary care or value-based care or team-based care, at their heart, they are also very much synonymous with whole health care delivery, whole person-centered care. We tend to spend a lot of time, especially those of us who live in the sort of the policy-ish world, we spend a lot of time parsing words and trying to find distinctions between this and that. And I think this is an effort to sort of think about what are the things that are common across all of those words and the people behind those words. And I think aspirationally, from the AAFP's perspective, our goal is to really bring those people together into one conversation instead of separate conversations. And we do think that all of this really fits nicely into what's happening across the payment landscape, because we are always focused on the things that we want, which includes the things that we don't want, and the things that aren't working as well, which, is fundamentally a fee-for-service payment mechanism that does not serve primary care well, because it doesn't pay for everything primary care does, because it undervalues the services that it does pay for. And that's that whole idea of paying for discrete services or tasks within a comprehensive relationship-based sort of primary care setting over time just doesn't make sense. And so for all those reasons, a lot of us, and taking NASM's leave, had leaned into the hybrid payment approach. And if we are successful, and again, bright spots, including some of the things in the proposed rule this year that just came out for the 2025 Medicare physician fee schedule, in terms of moving in that direction, recognizing that primary care benefits from a more sort of comprehensive payment that is recognition of the comprehensive nature of the care. And having said all of that, and I used a lot of words to talk about words, didn't I? But basically, I think that what that does is it opens up the lanes of possibility for physicians and primary care teams to adopt a wider range of strategies and models to really take good care of patients. And that's where lifestyle medicine, and I think the perspective that they bring, which resonates with me as an individual, like what would the kind of care that I want be? What would the kind of care be that I want for my patients? It's definitely, or for my family and my loved ones, it's definitely, that view that really says, first of all, what matters to you as a person? What goals do you have in your life? How are you doing at achieving those goals? And how can we help? I mean, that's kind of the fundamental track. And so, I just think this synergy is fairly natural, and right now is a really ideal time to be leaning into it.
It must have been so refreshing for you, Dr. Patel. If you have Karen Johnson as the big picture person, and she was talking about the different words that are used to describe, essentially the same thing, but she didn't lean in with controlling costs. She leaned in, right? She leaned in about how to improve the experience, how to improve patient care, how to improve patient outcomes. But she didn't lean in with controlling costs, which is what I think, as a clinical person in this space, that's what a lot of people they go in the wrong way. Did that have something to do with you working so well with Karen Johnson?
Well, I should say it's such an honor to actually get to know Karen personally and to work with her in last almost a year and a half. And I think her, this big picture sort of analysis giving us that, which is so helpful, but her passion and understanding of the value proposition of lifestyle medicine, I think is truly very, heartwarming. I think I'm always trying to look for supporters here because I know it works, truly. But I think it's always a difficult proposition to convince people why it works and how it works. So when you ask how lifestyle medicine truly, works in a value-based care arena, I would say the best part is that lifestyle medicine actually provides that framework, the clinical framework to deliver what we call as a whole person approach, right? So to integrate, say, for example, interdisciplinary teams, right, in a patient care and maybe in an office visit, to address root causes, right? So upstream focusing on being proactive and addressing lifestyle behaviors and helping patients move the change. But the most important thing is you say cost, right? So some of the early data that we have seen from our clinicians who have successfully integrated lifestyle medicine into value-based care models they look very promising. They showed almost 30 to 40% cost savings, total cost of care. So that's kind of exciting part for us. Yes, we never focused on the cost part because, most of us have always implemented lifestyle medicine in fee-for-service world, right? Where we deliver this high-value care that nobody cares, right? Nobody captures the value and sometimes actually it creates cost burden because how do you bring in interdisciplinary team? There are no special codes to bill for those services. So we've actually figured out how to actually deliver lifestyle medicine in both in fee-for-service world as well as in value-based care. And so it truly has the potential to not only deliver the quintuple aim that we talk about, but improving patient experience, patient outcomes, lowering the cost of care. But the most exciting thing is it improves professional satisfaction it brings that joy of medicine back. And that's the person sitting right in front of you, is because, I would have retired. I say this all the time, about 5-7 years ago, if I had not found lifestyle medicine, because I was done doing that traditional primary care. But it has truly brought so much joy and professional satisfaction. And I think that's what I really want to share with everybody, that this is really why we went to medical school, to really address those root causes and help patients improve their overall health and well-being.
You talked about in your article the lifestyle medicine vital signs, and I'm reading from your paper. It talks about physical activity, nutrition, stress, sleep, and emotional well-being. And most of us doing primary care, we have patients come in every day and they will say they've got these problems, but they want the magic pill for that. And we know that rarely does the magic pill is the easiest way to finish the visit and get the patient out the door, but it is not the way for long-term success here. So how do you approach the patient that comes in and says, I'm having difficulty sleeping, or I'm having difficulty, I feel really anxious all the time, and just give me a pill so I can get on and keep doing everything else that I've always been doing?
Yeah, and I think that's a great question. And I think that's a concern that people have, most people, especially if you have a 15-minute office visit. I'm talking about the fee-for-service world. How do you incorporate this, right? So I think there are a lot of ways to really include some of this assessment. It could be something that you give it to patient out of time or while they're still waiting in the waiting room. We have, in that article, we have shared some of the short assessment forms, which are easy to fill it out and patients can do it. I can tell you, because I practice as an internal medicine doc in a traditional primary care setting, and then change into lifestyle medicine integration. So I exactly know the both worlds. And my questions actually completely changed when I started practicing lifestyle medicine, because I never asked patients about their sleep. I never asked about their food, where they were eating. They were cooking, they were, eating out. I mean, that is such a profound way it's going to, affect their overall health. But we never talked about it. So we were just going straight to symptoms and then finding ways to treat those symptoms, right? And I think there are many ways to integrate these assessments and then creating that prescription, right? Giving that smart prescription, say, okay, this is what we're going to do. In addition to everything else that they're taking, medications, we're not taking anything off right away, right? So over the period of time, as patients improve, make small changes in their lifestyle behaviors, they feel so much better. And that in itself becomes their motivation to continue. And then eventually, obviously, we are able to successfully, take some of the prescription medications off. But that happens down the road.
Yeah, Dr. Patel, I remember when I first got into the value-based care space, we got to hear a presentation from Dr. Ornish. Dr. Dan, you remember Dr. Ornish's presentation from like 6-7 years ago about...
I remember the presentation. I don't remember the details of it.
Yeah, but how he was able to show that how lifestyle changes reverse coronary artery disease. And I remember it was early on in my value-based mindset shift. There's that shift of, seeing people and saying, okay, what can I prescribe for you? The quick magic pill. What's a magic pill? The magic test, and then on to the next person. And then making that mindset shift to looking at what the causes are rather than, and spending some of the time that you get with the flexibility of a value-based care environment, right? But then hearing Dr. Ornish kind of added fuel to the fire.
Yeah, I should say Dr. Ornish was also, someone early in my career that I was, heavily influenced by, because his work obviously, is groundbreaking, and he's the father of lifestyle medicine, we call him, because he literally demonstrated that chronic disease could be reversed, and especially, number one, cause of death in this country, heart disease. So his work is groundbreaking, and we all, and I don't know if you remember this recently, he also published data around early stages of dementia. So using the same lifestyle intensive approach to not only demonstrate, obviously he's done it with the heart disease, but now with early stages of dementia as well. So very, very profound work, and where we really we acknowledge his contribution to the field, and it's we're all grateful for, and we're all learning from, and he's still not given up. He's still very much into that research mode and continue to work and show what he can deliver. Yes.
Yeah, isn't it something that we've come to this extreme now with our current world, and now like going back to the basics, like that this is what is new now. Doctors who truly know their patients, the patients who know their doctors, they have an understanding for each other. There's a desire to learn more about each other. I feel like the fee-for-service system kind of, we reached the extreme, and now we're all kind of, the pendulum's coming back.
And that's what I was going to ask Karen. We have this shortage and worsening shortage of the primary care providers. Although I was reading an article somewhere the other day, and they were talking about we need to change it from primary care provider to the primary provider, who that point of contact is, and not just think about it being healthcare, but it's somebody that helps with lifestyle and things like that. What is it going to take from a policy standpoint to reverse this trend of shrinking access to primary care? Because if this is so important, it seems like we need to be training more people to help with this rather than fewer people.
Yes, and that all costs money. And you need the people to train, both those who are already in the profession as well as those who want to enter the profession. And so again, I think, I hate to say it all comes back to money. And thank you, Faisel, for noticing I didn't lead with cost. I do think, a lot of that is grounded in the sort of fundamental belief that, high quality primary care contributes to a really high performing healthcare system. And you don't get the latter without the former. And so if you just start with that, you can really focus on the elements that get us there, which is people who are trained to do the things that we know work well for patients, which is really helping at the root cause of the, before things go down a slippery slope. And, I did some study on this when I was finishing my PhD in health policy, looking at primary care payment. And it was always about how do you avoid those unnecessary high cost services? Well, you start talking with people before they need them. And that's fundamentally what primary care does, is it really gets to sort of that fundamental level. And I think, we've got to invest more in primary care. We've got to invest more in primary care at every level, both in terms of how we pay for the services that primary care delivers, so value-based payment. And we, of course, as you all know, do a lot of work at the AAFP on what that should look like. And we're increasingly trying to sort of get out of this, like, again, it's kind of a word game. Is it fee for service or value-based payment? Well, in reality, we know most of value-based payment today is really both. It's grounded in a lot of fee-for-service payment with some pretty bells and whistles on it in terms of bonuses and savings and structures and all sorts of things. So what we talk about increasingly is really well-designed primary care payment that provides prospective population-based payment, so that really do sufficiently resource primary care practices to be that sort of anchor point for patients in the healthcare system. I think in order to do that, and think about this just fundamentally, if you're going to make a prospective payment, then I have to know before a service is delivered which physicians and care teams are responsible for which patients. This is a huge mind shift for us to actually think about that sort of, and I think it does lead into what you were saying, Dan, about that primary provider, that primary point of contact. Of course, at the AAFP, we believe strongly in the family physician and then the physician role in all of this in terms of leading care teams. But it is very clear, family physicians are not going to solve this problem singularly. They need teams and resources and supports around them. And it's really equipping all of that through a primary care patient-centered lens that is really going to get us where we need to go. We've got to invest in training and retraining in order to sort of capitalize on that as well. But like I said, I think at the outset, I think we do see some bright spots in terms of payment moving that direction, both the recognition we need more, Look at the states. They're huge drivers in increasing primary care investment, setting primary care growth targets. Look at some of the things coming out of CMS and CMMI, actually including, like I mentioned, the 2025 physician fee schedule, looking at advanced primary care payments. I just think it's a time to sort of really lean in. And the last thing I want to say is it's not policy per se, but the word's been used a couple times here, and it was floating around in my head before you said it, Faisel, and that is mindset. So much of this in terms of how you deliver care is not about how you label it, but it's how you see it as a clinician or a physician and how you see your role in that. I was really inspired listening to the Senate Finance Committee hearings on chronic condition management some time ago. There was a physician from Iowa who I do not know personally. She's an internal medicine physician, but I loved her response on a very specific question where the representative was really trying to lead her down a path of sort of being critical of prescription drug costs and how that's being prescribed, which is, believe me, a lane we could run down if we wanted to. But I loved her answer, which is when he was asking about medicine she prescribes, and she says, well, I always start with the best medicine is no medicine. And how do we help the patient really improve their health by doing a lot of other things that we know are really impactful and effective. And this is not someone who labeled themselves as a lifestyle medicine clinician or a physician, was in a more traditional primary care practice. But I think it's that mindset and that thinking that I think is at the root of why these conversations are important for organizations like the AAFP and others to engage in.
And if I could add, I think the team-based care concept is kind of a novel and a new, right? A lot of physicians actually don't feel comfortable. I mean, some of them worry about their authority, but then there is also this concern around, how do you incorporate it? It's not something we learn as part of our training, so we are not comfortable. I think from delivering one-on-one care in my primary care setting to now, leading the teams, it's the best way you can deliver care. It is so much fun. And it really reduces the burden and pressure on clinicians. But obviously it engages patients, improves outcomes. It's really the right model that we need to adopt.
And if I could have one go back on the policy question, Dan, it would also be just to say, well, there's a lot of bright spots. We also have to just start talking out loud in more places about what's not working in the fee schedule. Fee for service is not going to go away, and I don't think it should go away. There are plenty of services in the healthcare system that continue to be those discrete services that don't need some other form of payment. You do it, you get paid for it, and you move on. And even some of those exist in primary care settings, but not sort of the core of what primary care, longitudinal primary care is. And so I think we have to continue to talk about things like budget neutrality and sort of the fact that A, it has not been updated, and B, that it applies only to physician payment. So if you look at those pretty graphs that show how much physician payment has been controlled over the years relative to other aspects of healthcare delivery, you have to scratch your head a little bit and ask, why is that happening? And then, that leads into other conversations about, facility fees versus site neutral payments and a whole host of things. But we have to have those policy conversations have to keep happening, and we cannot, move ahead and think that something better is just going to sort of, we can't remodel the house without fixing the foundation.
But having the way I was listening to somebody else's podcast this week, and they were talking about a physician who had I think this had been years ago, but he had been practicing in Texas, and he had a group of, I think, 500 physicians. And at one point, a hospital system wanted to, one insurance company wanted to buy them because they were saving so much money on the total cost of care. And another insurance company said, well, you're spending 10% more on primary care, not 10% of the healthcare dollar, just instead of spending 3% on primary care. They were spending 3.3% on primary care. You're too expensive. We want to cancel the contract. So, I mean, part of it is you've got to figure out who's doing the accounting and what you're being held accountable for. I mean, where primary care, I think, is successful is when you're looking at the total cost of care for the patient. And the long story, a hospital system finally wound up buying them, and they basically bought them and shut them down because they were costing the hospital system something like $100 million. That was a huge hospital system, and the primary care group was costing them $100 million because of the effective primary care. So, the host described it. Healthcare is where it's like going to a restaurant. One person orders the meal, one person eats the meal, and somebody else pays for the meal. And that's the thing that's so crazy about how all this works. It's not just negotiating with the patient. It's all these other players out there as well.
And Dan, I can't, emphasize enough, because this has become a big drawback for lifestyle medicine integration, because we are actually improving outcomes, reducing procedures and surgeries and, interventions on which hospitals benefit from. So there has been a lot of pushback from fee-for-service organizations, predominantly who get reimbursed on that payment structure. So yes, it is, even though we bring fantastic outcomes, there is a challenge to scale up the model or integrate in a broad way.
I was thinking about this. I was talking to one of my friends that I grew up with who has nothing to do with healthcare. And so he told me, I was talking to him yesterday. He said, I'd been to see my doctor, and he told me my cholesterol was high and wanted to prescribe a statin drug. And I didn't want to start taking medication, so I told him to hold off. And so he went and worked on his diet and exercise and lowered his total cholesterol from 220 to 185 without taking a statin drug. But now I was just sitting there thinking, well, but his primary care provider's getting dinged for not providing the statin drug to somebody with hyperlipidemia, right? Well, how do we approach quality? Not just what's easy to measure, but what actually provides better outcomes for the patients.
Yeah, and you brought up this really pain point that we go through as an organization and our clinicians suffer from. These are misaligned quality measures, right? So we just don't have quality measures that talk about lifestyle interventions. It's straight to pharmacy, straight medication adherence, and that's all we care about. So we are actually working with, National Quality Forum and other, including CMS, to really raise awareness around this, that there are clinicians who actually are prescribing, diet, exercise, and other lifestyle behavior change before prescribing a statin. So they should not be dinged. Their, in fact, clinical outcomes could be significantly better than just using a standard statin prescription. So it's a challenge because our current framework is designed on chronic disease management, right? So we get reimbursed for having a disease. Even in value-based care models, our clinicians who actually put chronic disease into remission, for example, diabetes, if you take that off, it reduces your risk score, right? And it reduces the incentives tied to it. So this is a bigger problem that we're talking about, not just improving patient outcomes, but at the same time, we don't want to create a system which actually penalizes clinician to doing the right thing. So yeah, it's a systemic problem. And you'll be surprised that in our conversations with CMS and CMMI and all, this part was very surprising to them, that improving clinical outcomes, putting chronic disease into remission is actually penalizing clinicians. I think it was a kind of a aha moment for a lot of them. Hopefully we will see some new regulations, new way that they will design models where hopefully we will see clinicians who have more healthier populations, right, would have some incentives, right? I mean, right now you only have incentives in keeping people having all the chronic diseases on there, right? There is no incentive to reverse them. And so I think someday we need to get there.
I'm going to jump on my measurement soapbox for just a second. And when I do that, I bring out my history book. So I started in this business many moons ago. as a benefit consultant working with large employers who were self-insured. And I started in this business before we had this thing called HEDIS. And I will just say that at that point in time, we were all clamoring for some indicator of quality. Like, what's quality? If we're going to pick a network. And back then, I'll also say we didn't have networks that had everyone in them. We had some more discrete networks. So when you're helping guide an employer through selecting a plan, which meant a network, which meant leaving some people out, you really wanted to understand quality. We had no visibility or transparency into quality. And so we had this thing called HEDIS that was created, and it was just magical and wonderful because all of a sudden we had some understanding of healthcare quality. Of course, it was built on claims data because those were the only data that we had to understand quality. So fast forward 30 years, and we have a lot more data. We have a lot more visibility into sort of what works within systems. But what we continue to lack is transparency and sort of that broader understanding of both cost and quality of care. So we could get at data far beyond claims data today. Again, back when we were doing HEDIS, everything was in a paper chart. Very difficult to get at outcomes when everything's in a paper chart. That's not the case today. Again, bright spots abound in the data standards world and in the movement toward, digital or electronic, quality management and the opportunities that presents. But we've got to sort of always continue to sort of question why what we have, and talk about the things that aren't working and why we need to move forward just as much. So it's time to sort of let the claims data be the claims data and not the gold standard for understanding how our healthcare system is serving patients today.
That's sort of where the whole risk adjustment rubric came from with HCC coding, right? I mean, they had to figure out a way to do risk adjusted payments after the first round of managed care failed, but everything was on paper. So they really, they were sort of left with picking diagnosis codes to go there. Today with everything computerized, you would think there would be a way to actually look at risk adjustment based on outcomes and total cost of care. It seems like maybe where things go sideways is where you start basically teaching to the test, right? So it's about how to get these quality measures rather than take care of the population of patient and get good outcomes. And the byproduct is these quality measures look better. Whereas everybody who went to medical school got really good at taking tests, right? And so if you're going to give me you're going to give me an A plus if my average blood pressure is, 120 over 70 or whatever. The problem is if we say it's just a true average across my population, well, that would give me incentive to drive the wrong people's blood pressure too low. And then for, some of our elderly patients, they really need a blood pressure of 160 over 90 to perfuse their brain, and they actually get symptomatic when you lower it. And so then the question is, how do you make the right decisions without penalizing yourself in those quality measures?
Yeah, so we are fans of the work that is happening around primary care measures that matter. So if we're talking about primary care, we do have some in practice today in use. The person-centered primary care measure is one measure that really gets at sort of the heart of the physician-patient relationship or the clinician-patient relationship. And really, from the patient's perspective, is this working? Is this serving my needs? There's a comprehensiveness measure in development. There's a continuity measure that I think has been implemented. So those more comprehensive measures, at least through the primary care lens, feel like the right way to go in terms of, really evaluating primary care as a component of care. And then it's really all about outcomes, which you can ask the patient, you can, get at that in a lot of different ways. I think, do I feel better? Am I healthier? There's a lot of ways to measure that.
Especially over these last few years, you feel it, even from the patient side, with COVID, with people dying younger, of course, because of COVID, but then even after, where the general public even in our clinical time, they're coming in saying, wow, life expectancy is going in the other direction. Everywhere else, it's increased. And in America, it's for the first time going in the other direction. It's much, much more readily known that medical debt is a major cause of bankruptcy, the number one cause of and that the providers are burnt out. That you have this trifecta of like, you cannot deny that a change must happen. And the timing is ripe. I think the timing is right.
Karen, maybe you can answer. If you think AI will help us with maybe HCC coding / maybe quality measures, do you see any hope in that direction?
Oh, I think it's already demonstrated that it has great potential in that regard. I mean, it's really good at finding information and sort of pairing information together. So that's one of the sort of really easy early strengths of AI is how can I find in my chart the things that are buried deep within it. We work a lot on how do you get the right information to primary care practices in order to sort of manage this comprehensive view of a patient. So not just what I'm doing for them on a primary care basis, but if I'm taking accountability for that patient, there's going to be some level of cost and quality accountability that's probably happening outside of my practice that I need to understand. And so I do think, that as the information comes in, how do I ingest that and use that? AI will definitely play some roles in that from an administrative point of view. So I think that's a really important piece of it. And I think, the other thing that I think about just broadly from a policy perspective that we haven't really touched on that I think is an important part of the conversation is transparency in general. And I think especially as it relates to cost and quality of care, I guess we've touched on it a little bit. Dan, you made me think of this earlier with something you said, I know. But, this idea of how much does care cost is such an unusual and ironic mystery. I mean, I compare it to sort of like, imagine that we all bought airline tickets. We reserved a seat on a plane and they said, well, the cost is maybe going to be somewhere in this range, maybe, or not. But here's the deal. We'll send you a bill after you land. And the cost of that trip is going to be variable based on how many people are on the plane, how much food is consumed, how much gas is used, how long you sit on the runway, what weather you encounter, go down the list of variables. But that's essentially, if you enter anything more complex than a single visit in the healthcare system today, that is the world you're entering, one in which you do not know. And I'm thinking about this from a patient lens right now, or speaking to it from a patient lens. Wouldn't we all love to know what something's going to cost? But the answer is almost always they can't tell us. So think about that and think about the primary care physician and clinician who's really trying to manage cost and quality on behalf of a patient population. We've got to have better sort of visibility and transparency on what is the cost and quality of care throughout the ecosystem. Otherwise, how do you make high value referrals to specialists or to facilities that are both going to deliver a good outcome, but also at a reasonable cost? Right now, most primary care physicians are flying blind when it comes to sort of that element of really success. And I think that's one of the things that we're going to have to really address at some point.
Very often the primary care physician is the one ordering the meal, right? We're the ones referring the patient to the specialist, but we don't know what that cost of care is. I mean, one thing that I've noticed interesting in our EMR, at least with one payer here in Virginia, is that for a long time, our EMRs had the ability, if I went to order a prescription for a patient, it gives me an estimate of what their out-of-pocket cost is going to be at that pharmacy versus mail-in, which is helpful. But now one of the insurers has put it in, and it tells us what the plan cost is. So not only this is what the patient's going to pay, and when you're in a full risk model, this is what we're paying for the drug. That's something that's actually pretty important to know, because you don't know what the different drugs cost, but you sort of need that when whatever you order, right? Whether you're ordering a CAT scan or MRI or ultrasound or the different lab tests, and that just really doesn't exist anywhere that I'm aware of. That so what you're asking somebody to pay before you place the order. But
yeah, there's a cost when we don't know what the cost. I mean, we're paying for what we don't know. We all are. across, with the physicians and the patients, of course. Yeah.
But the other thing I would say is most of the large health systems, accounting systems, aren't sophisticated enough to actually, for that they know what the cost of providing care to an individual patient is. They know what their average cost per admission is, and they may even know what their average cost for providing care for a pneumonia admission is. But as far as knowing what it costs to take care of Dr. Faisel Syed with his pneumonia, they don't have that ability to actually know what it's costing and whether they're making a profit or loss on each patient encounter, each individual patient encounter.
But, this takes us full circle, I think, back to sort of that original part of this where we didn't start with controlling costs, because I don't think that primary care controls costs necessarily in this way as much as it does through the things we're talking about relative to lifestyle medicine and really treating root cause and really engaging patients and really understanding their why and helping them to, really achieve their best health as opposed to manage illness. Now, certainly managing illness comes into play. It's inevitable. It's going to happen. But that if we focus on sort of those core elements as primary care, the management of the costs takes care of itself because you avoid, it goes back to that, we avoid those high cost services that are really fundamentally not needed if the other care is happening when and how it should.
So, Karen, are you saying that they first if you're a doctor, you're a primary care doctor out there, your margin is you're the 2 to 3% margin for your practice. The first step is they got to advocate for a value-based payment model. And then where do they go from there?
Yeah, I think, one of the complexities and where my mind goes when you ask that question is well, do I own my own practice or am I employed somewhere? Because those are two very different experiences. And I think we all know what's happening, which is that you have much less of the former, those who own their own practices, and much more of the latter, those who are employed within health systems. And so, our work at the AAFP extends beyond, thinking about how organizations are paid, because value-based payment is really fundamentally about how it's a B2B contract. That's an organization to organization contract that's happening. And what the organization chooses to do with the financial, implications of those contracts is really up to the organization. So there's really a couple conversations to have. One, it's empowering and equipping independent practices to take advantage of the landscape of payment opportunities that exist, which is something we do every day, all the time. But I think it's also increasingly thinking about the organizations that employ family physicians, which is increasingly a smaller number, as we also know, as consolidation continues to be pervasive across the healthcare system, but especially within the primary care sector. How do we empower those individual physicians working in those employment settings, but also how do you reach those employers of family physicians in ways that help them maximize the value of their workforce? Because we all know that family physicians are pretty powerful in what they can contribute. And I do think it is just at some point, and Dan, I happen to know the physician whose story you tell from the podcast, and have heard that story more than once, where, the success of primary care does not feed the traditional hospital financial engine. And I think my hope and belief is that there are more and more of those organizations that are starting to think maybe differently, but they're not going to think completely differently until their financial incentives have also moved to the degree that we're trying to move the incentives for primary care. So again, from a policy perspective, when you talk about what's in the best interest of primary care, it's not just changing primary care payment, but it's also really thinking about the incentives across the whole of the healthcare delivery system. And how do we align the incentives of others around supporting primary care as truly the foundation of a high-performing healthcare system, and not just a feeder mechanism to other services that in the near or short term might be more profitable for an organization.
And if I were to add just one more thing in a very short way, quickly we could address, and I think people don't talk about this very often, is these RVU-based compensations that primary care clinicians are tied to. I think that creates so much burden and burnout. It's just because you are in this perpetual, will, a 15-minute encounter, you have to generate the revenue, you have to see X number of patients. And I think that is something that we need to kind of raise awareness that we need primary care clinicians should not be reimbursed on that model of compensation.
So Karen and Dr. Patel, if I'm a doctor and I want to start embracing and start understanding some more with these lifestyle medicine principles, where can I go to get some CME or education, either with the AAFP or the ACLM?
So we included a pretty comprehensive resource inventory in the article that we published in the American College of Lifestyle Medicine. So if there's a way of making that available to your listeners, I would certainly encourage you to do that. And I think, in it, I think we're pretty clear that there's really a plethora of resources out there for those who want to learn more through the AAFP, through the ACLM, through a wide range of organizations that really do believe in the merits of lifestyle medicine as a contributor to high quality primary care.
Yeah, and American College of Lifestyle Medicine offers education, CME courses, as well as certification, American Board of Lifestyle Medicine, but also a lot of patient resources, education, practice tools, reimbursement tools, and so forth. So even for non-members plus for members, so there's a lot of free material that you could access at our website. But also there are, if you become a member, obviously there are additional benefits.
Wow, Dr. Dan, what a great conversation. Dr. Patel, Karen Johnson, thank you so much for joining us today. I mean, we can transform healthcare delivery. I mean, this is how. With exploring how value-based care and lifestyle medicine works together, we can transform healthcare delivery. And perhaps we should focus more with today's conversation was about the mindset shift that's needed to make that happen.
Absolutely. And empower patients and clinicians.
And thanks to the two of you for what you do to keep beating the drum and spreading the word. It's important work, and so honored to be just a small part of it. So thank you.
And same here. Glad to be part of this wonderful conversation and appreciate all the work that you both are doing. Thank you.
What are your thoughts on fixing the foundation, rebuilding with lifestyle medicine? You've heard ours. Now we want to hear yours.
Email us at faiselandfriends@gmail.com, and your question could be featured on the podcast.
If you like this episode, leave us a review and tell us how we're doing. And don't forget to subscribe wherever you listen to podcasts so you never miss an episode.
Connect with us on social media by following Faisel and Friends.
And follow Primary Care for America on LinkedIn and Twitter.
I'm Dr. Faisel.
And I'm Dr. Dan.
And thanks for listening. This podcast is brought to you by Primary Care for America Collaborative and produced by Split Prism Productions.